All right, well, thanks everyone for joining us tonight. My name is Brennan. I work for CTC Communications, which is a medical education company. I'll be hosting / moving the slides for tonight. We've got Dr. Yale and Dr. Gregoire to give us a nice clinical update on some of the more recent developments in type 2 diabetes and cardiovascular disease. And we're excited to have them, and we're really looking forward to the lecture. So with that, I'll pass it over to Dr. Gregoire.
Yes, thank you everyone to being here tonight. This is the current agenda. We will review some interesting data regarding the cardiovascular safety and outcome trials in diabetic with a new class of anti-hyperglycemic agent. After that, some review of the Diabetes Canada guidelines. We will have a case discussion and question and answer, and the session should be closed at 7:30. I have the pleasure to have Jean-François Yale, as you know, is a professor, Department of Medicine at McGill University, and a well-known endocrinologist, and myself, Jean Gregoire, Associate Professor at the University of Montreal, and a cardiologist and interventional cardiologist. Next slide. What we know is diabetes and cardiovascular disease are very related. And we know that diabetes is a very strong risk factors to develop coronary artery disease. People with diabetes usually have 2 to 4 times more likely to develop cardiovascular disease than those without. And as you know, many patients with diabetes will die from coronary heart disease. Next slide. Regarding the risk of heart failure hospitalization and the risk to develop heart failure, what we know here, we compare the red line versus the black one, and we see for diabetic population, the risk to develop heart failure is significantly increased. You see this relationship at the left panel, and the risk to be hospitalized for heart failure is also increased significantly in this population compared to non-diabetic population. Next slide. What we know that diabetes is a strong risk factor to develop coronary artery disease. This means that the patient with type 2 diabetic are higher risk for atherosclerosis event. This means that they are more prone to have coronary disease and then myocardial infarction. And the relationship between MI, as you know, and low ejection fraction, because you reduce the number of smooth muscle cells or the myocardial cells that could do the contraction, then this could be a very good cause or etiology to be with a low ejection fraction and to have heart failure as a manifestation. But also, we know that patients with type 2 diabetes are most prone also to have some inflammatory effect on the myocardium, and then we can develop also heart failure without coronary disease. This means that diabetes patients could have heart failure related to atherosclerosis process or myocardiopathy. Next slide. The relationship between diabetes and heart failure, people with diabetes have 2 to 5-fold more risk of developing heart failure because they are more prone to have concomitant coronary artery disease. We just discussed the effect of diabetes on the ischemic or diabetic cardiomyopathy. Also, we know that diabetes population, usually there are a link between the diabetes and high blood pressure, just related at least to the cardiometabolic syndrome. Also, diabetic patients are more prone to have extracellular fluid expansion and concomitant renal disease. There are some important risk factors for hospitalization for heart failure. Patients with diabetes with previous heart failure are more inclined to develop hospitalization. Also, the patient with the low eGFR, defined as eGFR below 60, usually this is a very strong risk factor to develop heart failure and then to be hospitalized. And also the baseline NT-proBNP. Patients with higher level of NT-proBNP are more prone to be hospitalized and to develop heart failure. And as you know, also patients with diabetes that have acute coronary syndrome, usually they are high risk for dying for their disease, and the risk of heart failure after ACS is worsened as an increase in patients with diabetes compared to non-diabetic population. Next slide.
So good evening, everyone. So of course, when we consider the treatment of type 2 diabetes, there's traditionally two goals that we have. Certainly having a good glycemic control is one of them, and we have the many classical agents to do that. And on the other side, we also try to prevent microvascular complications through vascular protection using therapies such as aspirin, statins, ACE, or ARB, depending on the population. Now, certainly what we know is that some of these agents actually can have a dual role, if you can have next slide, in the sense that the SGLT2 inhibitors and the GLP-1 receptor agonists have been demonstrated to provide vascular protection as well as glycemic control. And these agents now become having a dual goal, so that in some cases we'll preferentially select these agents when we need vascular protection as well as glycemic control. Next slide. So there are many cardiovascular outcome trials that have been completed. What you see here are the ones that were completed with DPP-4 inhibitors. So these were FDA mandated. They wanted, after what happened with rosiglitazone and the thiazolidinediones in general, they wanted to prove that there was no harm in giving these agents at a cardiovascular level. So the goal of these trials was to prove safety. And in the DPP-4, essentially safety was proven. The MACE was not significant. There was no benefit, but no harm. There was a signal for an increase in hospitalization for heart failure with saxagliptin, but it was relatively small. Next slide. Subsequently, we also had some studies on GLP-1 receptor agonists, and this time we started having some interesting results in the sense that not only was there safety, but there was actually a benefit. Particularly with liraglutide and semaglutide, there was some benefit at the primary outcome of MACE. CV mortality was reduced with liraglutide, explaining most of that reduction in MACE. And with semaglutide was more the non-fatal CVA that were responsible for that. Both of these trials showed also some improvement in the renal outcomes. And similarly, next slide, it was okay. What we have are the trials with the SGLT2 inhibitors, which really provided some evidence that they had some fairly dramatic effects to reduce heart failure, have major events, improvement in terms of the renal outcomes. And for two of them, they had actually an improvement that was seen in MACE, and in one case, empagliflozin, a reduction in CV and total mortality as well. So these trials revealed some benefits where if people have high risk of cardiovascular disease, which was the majority of the patients in these trials, it could be preventing further damage and certainly reducing for SGLT2's heart failure. Next slide. Now, when we compare these trials for the SGLT2 inhibitors, it's a little bit difficult to do so because the populations were so different. If you look, for example, at the MACE composite outcomes, you might see that the results with empagliflozin, the ones with canagliflozin in yellow were significant, but that the MACE was not significant with dapagliflozin. Does that mean that the three agents are different? Not necessarily, because if you look on the right side, you can see that the populations of these trials was extremely different. With the EMPA-REG trial, it was 100% with established cardiovascular disease. In the CANVAS trial with canagliflozin, you had about 2/3 with established cardiovascular and 1/3 with multiple risk factors, so people at risk but without an event. Whereas with dapagliflozin with DECLARE, you had only 40% with established cardiovascular disease, 60% were in primary prevention. So it's difficult in those circumstances to compare the three drugs in a way which is fair. Next slide. So one way to try to make them a bit more comparable is to separate in these trials the patients with atherosclerotic cardiovascular disease, secondary prevention, or patients with only multiple risk factors and therefore so-called primary prevention in this case. So if we look at the effect on MACE, so infarct, cerebrovascular accident, stroke, and mortality, what we can see is that when we look at the patients with atherosclerotic disease, when we do a meta-analysis of these three, it's significant, 14% reduction. There's no heterogeneity, so it suggests that it's a class effect, even though one of them with dapagliflozin declare is not quite significant. It's just borderline. But when you put the totality of the data, it suggests it's probably a class effect. On the other hand, in primary prevention, patients with multiple risk factors, the two studies that had such patients, canagliflozin and dapagliflozin, seems to suggest no effect at all on this particular outcome. Next slide. Now what you have here is the hospitalization for heart failure. Did you want to say something, Jean? Or?
Yes, no, keep going if you want. Go.
Okay. So this is the hospitalization for heart failure and cardiovascular death. So the same concept, you have patients with atherosclerotic cardiovascular disease. Here there seems to be an effect that is quite clear in terms of the secondary prevention. When you do the meta-analysis, it suggests a 24% reduction. And in patients in primary prevention, it's sort of borderline. There's certainly a signal that's there, not quite significant, but certainly going in the right direction. Next slide. If you take out cardiovascular deaths and only look in isolation to hospitalization for heart failure, in these cases, the meta-analyses become positive, whether it's for secondary prevention with about a 30% reduction, or in primary prevention with, again, a 35% reduction. One of the studies, Canvas, was not significant by itself, but when we put the totality of the data, it suggests it is. So what this suggests that, to me, it's probably that there is a certain class effect. In secondary prevention, we talk about effects on the MACE, but on heart failure and renal, we have a more generalized effect. Next slide. Oh, and I think I was taking your slide, Jean, so you can continue.
No, that's okay. But I think this relationship is interesting because in the AMPA-REG, I think this is, as you described, is very big trial that show in secondary prevention population a very strong benefit with this class of medication, because 100% of the cohort were patients in secondary prevention. But when we're looking at the relationship for hospitalization for heart failure, what we see is a very special relationship, because very early in the trial, the curve diverge and continues to diverge over time. This means that the benefit of SGLT2 inhibitor, and here is empagliflozin, is very early, and the benefit continue over time. And as you know, the reduction is very important. At the end, the percentage reduction was 35% relative reduction of heart failure in this population. And we know that to be able to prevent heart failure hospitalization impact for long-term about prognosis. I think this is very interesting, and we see this relationship also with the CANA in CANVAS, the same kind of relationship. And in DECLARE, because we're dealing with patient with normal EGFR, this means EGFR above 60, this relationship is there, but probably less evident. The reduction at the end of the trial is close to 15% compared to 35 to 32% with the CANA or AMPA, but we're dealing with different population, and is why it's important to compare one trial to another, because the population are so different. Next slide. This is you.
So when we look at the renal outcomes, again, the same kind of meta-analysis was done, and certainly both for patients in primary or secondary prevention in this case, when you look at the meta-analysis, there's a huge benefit that seems to occur. So the fact of having a severe worsening of the renal function is reduced almost by half in all the patients and all these studies. So this is a very strong effect, very reproducible, affecting both populations, more or less severe cardiovascular impact. So the renal effects are really spectacular with this class of agents. This was, of course, supported as well by the Credence study that with canagliflozin that was just released, and where a similar kind of major effect of prevention has been seen. Next slide. Now, one thing that's important to realize when we look at the eGFR, how it evolves when we start using these agents, there's an interesting aspect is that immediately when we start these agents, there's a drop in the eGFR. This drop is usually of the order of about 4 to 6, sometimes 8 mLs per minute. So sometimes it can be frightening. In the example shown here, it goes from 76 to 72. Nobody would be too worried. But of course, if it goes from 36 to 30, it's more frightening in terms of decrease. So initially, we're a little bit worried about this reduction. What has come out with all these studies is that actually there's a protection. This decrease is probably related to reduction in the hyperfiltration and in the hypertension within the glomerulus. So what we're seeing is really the real eGFR after that drop. And then the protection manifests itself by a very flat curve over time. In contrast, the people not treated with SGLT2 inhibitors do not have an acute drop in green, but they slowly come down with diabetes evolving over time. So after about 1 year, they're about the same, but subsequently, more and more, we see the beneficial effect of the SGLT2 inhibitors, whereas the reduction continues and continues with the placebo group. So what's important here is that if you do measure the eGFR close after the introduction of the drug, or even if you do it a few months later, you have to expect there will be a reduction, and that's okay. That's part of the normal impact of these drugs. And usually it's accompanied by a reduction in microalbuminuria or macroalbuminuria, which can also be a sign of the effect of the drug. Next slide. Now, one of the effects in these meta-analyses that came out is what is the risk of amputations. We know that the risk was highlighted in the CANVAS program, so there was an increase, about a doubling of the risk of amputation in these patients, going from about 3 per 1,000 patient years to about 6. In the other two trials, this was not seen. So with empagliflozin, it was not seen, and with dapagliflozin, was not seen. Is it because of different populations or different ways of initiating the drug? We know that canagliflozin was the first program to actually start recruiting patients, and at the beginning, patients were entered either as 100 or 300 milligrams straight on with no adaptation. Was there more hypotension, perhaps, or problems? And that might be less present now that we know these agents a little bit more. Certainly, what we know is that the most recent trial, the Credence trial in patients with diabetic kidney disease, so a very high-risk population for amputations. In that large trial, there was not that signal that was present, so that's a little bit reassuring. But certainly, it's something we continue to be careful when we do the meta-analysis. There is sort of a significant effect, but there is heterogeneity in that analysis between the three agents. Next slide. There's also the risk of ketoacidosis with SGLT2 inhibitors. There's roughly a doubling in all the trials. It's a very consistent effect. There's no heterogeneity. Now, fortunately, it's very rare in patients with type 2, so we're doubling a rare event. So in terms of number of cases, it's small, and it's usually not in a blue sky. It's usually at the time of an intercurrent disease. So it's important to counsel these patients well in terms of having to stop the drug in those circumstances when there's another concomitant disease. Next slide.
This slide summarizes nicely the cardiorenal benefits with the SGLT2 class in different populations. And what we can say is regarding the MACE, mortality, heart, and stroke, mostly patients in secondary prevention would deserve a strongly benefit compared to primary prevention. As you know, in the DECLARE, there is no such benefit in primary prevention, same thing in CANVAS. But regarding the secondary prevention patient, this means that patient that having an event in the past, this population deserve a strong benefit regarding the MACE reduction. For patients with primary and secondary prevention, what we observe with SGLT2 trials, both populations have a very strong renal protection and very strong reduction of heart failure hospitalization. This means that if you're dealing with patients in primary prevention, with diabetes and secondary prevention, usually we can expect to have a renal protection in both populations and heart failure reduction. But regarding the MACE effect, this means the major cardiovascular event, only patient in secondary prevention will deserve a strong benefit of SGLT2 inhibition. Next slide. There are multiple possible mechanisms that could explain the cardiovascular benefit with SGLT2 inhibitors. We don't know yet what's the benefit because when we're looking at the Kaplan-Meier curves with SGLT2 compared to placebo, what we observe is very early benefit regarding the cardiovascular event reduction, also the cardiovascular death reduction. This benefit occurs very, very early when you start the trial. There has been many discussions about maybe the three potential mechanisms that could explain the strong benefit related to this class of medication. We know that there are a very strong effect of hemodynamic. We reduce the volume, you increase the hematocrit, and this could explain part of heart failure benefit, sure. We know that maybe we're using the ketone, that could be a super fuel hypothesis, and maybe also with the class of medication, we improve oxygen delivery in the cell. But still in 2019, we don't know exactly what is the mechanism. Probably this is not only one mechanism, but a combination of many that could explain the very strong benefit regarding the cardiovascular event reduction and the kidney improvement in this population. Next slide. This is related, this slide describes the first part of the Diabetes Canadian guidelines. And what is important and to put a lot of emphasis on the LT behavior intervention in patients with diabetes. This means that we have to modify the way patient eat, patient live, try to manage the weight, increase the physical activity. And the first drug that we have to prescribe is metformin. And the first question physicians should ask in their patient, is there a clinical cardiovascular disease? And the cardiovascular disease is described as the clinical manifestation of cerebrovascular disease, heart manifestation as heart unstable angina, patient with hospitalization with STEMI or non-STEMI who had revascularization, this means with CABG or with the PCI and stenting, and patient with peripheral vascular disease. The answer is yes. The recommendation is please, on top of metformin, introduce a drug that could prevent and demonstrate cardiovascular benefit. And we're dealing about the SGLT2 inhibitor, mostly the empagliflozin and the canagliflozin, and also the GLP-1 agonists, such as liraglutide, for example. And I think this is very important because the first goal when you're dealing with patients in secondary prevention is to improve their outcomes and reduce their event. Next slide.
So if we look at the actual recommendation in the guidelines, the way it's stated is in adults with type 2 diabetes, so it doesn't apply to type 1, with clinical cardiovascular disease in whom glycemic targets are not achieved, because that was one of the conditions to enter the trial, with existing antihyperglycemic medications, and with an eGFR above 30, which was also one of the conditions in the major trials with these three drugs, an anti-hyperglycemic agent with demonstrated CV outcome benefit should be added to reduce the risk. So for major CV events, so for MACE, you have the grade A for empagliflozin liraglutide, grade C for canagliflozin. For heart failure, you have empagliflozin, canagliflozin, and for progression of nephropathy, again, the 2 SGLT2. So this was, of course, written before we had the data with dapagliflozin, which is therefore not present in this particular recommendation. Next slide. So the 30 is something that was a little bit of a surprise because when these studies were initiated, the product monographs were saying do not start these agents unless the eGFR is above 60. But the trial did allow patients to enter that were between 30 and 60. And clearly, whereas the anti-hyperglycemic effect is less when the GFR is between 30 and 60, because there's less glucosuria, these trials have shown that the benefits, both for the kidneys and for the heart, were the same when people are between 30 and 60 and above 60. And therefore, that's why the recommendation goes as low as 30 mLs per minute. Next slide. So the way it's presented in the guidelines, you have a table with the different agents and their characteristics. That has been a traditional table in the guidelines for many, many years. Previously, the order of the agents was by alphabetical order. It was decided that it was probably more logical to find something else for the order. So what was decided was, because it was so important, to use the effect on CV outcome as the way of deciding which ones would be first in the table. So the two classes that have shown some superiority in terms of cardiovascular benefit are listed first. Subsequently, the ones that were proven to be neutral, to be safe, the DPP-4 inhibitors, insulin, and TZDs come next. And finally, there are many agents that never had such trials, such studies, and they are listed later because we know less about their characteristics. Of course, the table then lists other aspects which are important when we treat diabetes. Hypoglycemia is mostly related to the use of insulin or secretagogues. The body weight, similarly, is mostly with insulin and secretagogues, as well as thiazolidinediones, which are less often used. But they are, of course, the benefit of weight loss with GLP-1 receptor agonists and SGLT2 inhibitors. In terms of potency to reduce A1C, they all do it. That's why they're in this table. But certainly the newer agents are amongst the strongest. So again, the SGLT2 inhibitors and GLP-1 receptor agonists, it's another reason to prefer to some of the other classes. Only insulin can compete with these in terms of the A1C reduction. And finally, at the end, there's a cost and, of course, coverage by RAMQ that will have an influence, as we'll talk a little bit later. Next slide. Another aspect, so of course, is the renal function. Whenever we select some agents, you have here the Diabetes Canada version in 2018. So what comes out of this is the fact that when you look at the SGLT2 inhibitors towards the bottom, you can see that on this, empagliflozin is allowed down to 30. That is now in their product monograph. Canagliflozin is officially allowed down to 45, but with the results of CANVAS, I think it's quite reasonable to say it should go down to 30. And dapagliflozin, with the recent results of DECLARE, is now allowed to, and as well as some other studies more specific actually for renal function, it's now allowed in the product monograph down to 45. So more and more these limitations in the use of SGLT2s are going away. There's an updated version of this table present on my website if you're interested at dryale.ca. When you look at the GLP-1 receptor agonist, we can see that most of them can use quite late, liraglutide down to terminal renal failure, and dulaglutide can actually be used even later up to dialysis. And the same would apply to semaglutide, not in this table because it was not available at that time. So certainly renal function is important to consider, but much more liberal now than it used to be previously. Next slide. So when there is no cardiovascular disease, what do the guidelines say? They say that we should individualize our choice based on the characteristics of our patients. And amongst the most important clinical considerations, and it listed separately from the others, we often have avoidance of hypoglycemia and or weight gain with adequate glycemic efficacy. When these are important priorities, again, it's GLP-1 receptor agonists and SGLT2 inhibitors, but the DPP-4 inhibitors that are favorable at that level also get into that group. And of course, many other considerations will bring us to choose, and that will include cost and coverage and patient preference, of course, as well. Next slide.
We'd like to describe a case, the Irene case. Irene is a 59 years old woman on RAMQ insurance. She come to my office for annual follow-up in cardiology. She had an angioplasty with the 2 stents in 2014. Her BMI is 33.5 kilogram per meter square, and the blood pressure is 114/72. She had a diagnosis of type 2 diabetes since 2011, treated currently with a combination of sitagliptin plus metformin, gliclazide 60 milligram daily, a statin, ACE inhibitor, beta blocker, and aspirin. Her A1C is 7.1%, LDL nicely below 2 millimole per liter, 1.31, eGFR 55, and albumin creatinine ratio at 1.7, and she feels very good. Next. The question, she's looking good, but based on what we review tonight, there are some interesting and important points that we have to stress here. Next. First, she had a clinical cardiovascular event. Based on the current guidelines, she has to be treated on SGLT2 inhibitor or GLP-1 agonist. Next. She has frequent hypoglycemic episode also that she did not mention spontaneously. Next. And if she was not on secretagogue, we could aim for an A1C under 6.5%. And we know this is a young lady, and we have to protect the heart. We have to reduce the cardiovascular event, but also, if it's possible, to have some impact of a microvascular disease. I think this is going to be helpful for the patient over time. Next slide.
So one of the aspects when we discuss with the patients what will we do is to explain to them the characteristics. It's often useful to simplify when we talk and to have something visual. This is an example of a table that shows the characteristics of what might be choices for patients after the use of metformin. Next slide. So it lists the different agents, which ones are tablets or injections, shows the potency, which ones are the most potent for glucose reduction. Next slide. The effects on the body weight, so some cause weight gain, some cause weight loss, and some are neutral. The effects on hypoglycemia, where it's mostly sulfonylureas, secretagogues, as well as insulin. The effects on the heart, which are, as we've seen, related to SGLT2 and GLP-1 receptor agonists. The benefits on the kidneys, which are mostly SGLT2 inhibitors. It's important to discuss other adverse events, of course, with these patients. The most common ones with sulfonylurea, it's the hypoglycemia. With the SGLT2 inhibitors, what patients will notice most is mycosis, so related to the glucosuria. That can be prevented by giving a cream for men or pills of fluconazole for women as a PRN prescription. GLP-1 receptor agonists will be mostly nausea for the first few weeks in about 15% of people. When we say nausea, it's more a feeling of fullness. And finally, it's important to discuss with the patient their coverage. So what's the RAMQ coverage on the next slide? So showing, next slide, please. No, okay. I guess the RAMQ did not show if you come back. So usually there's a column here that should appear that says what is a médicament d'exception. So the sulfonylureas are on the general listing. The SGLT2 and DPP4 inhibitors are on médicament d'exception, but with a code. So that's fairly simple. GLP-1 receptor agonist is médicament d'exception, but you have to fill out a formulary, and insulin is neutral. So we see that on the next slide. with more details, where you can see that what the codes are for the different medications. So when it's added to metformin, if they've used sulfonylureas before and had problems, or if it cannot be used because of contraindications, that's the big column, the large column in the middle. So that's where you see most of the codes, both for the agents and when they're in combo with metformin. There are also some codes if you don't use metformin, if it's in monotherapy or only with sulfonylureas. And finally, there's a special code, which is a fairly recent one with empagliflozin following the EMPIRE trial. There's the code if there's cardiovascular disease and A1C above 7. You don't need to use secretagogues before. You can go directly to use the empagliflozin with the code EN179. So it's a recognition by the RAMQ of the importance of this CV protection. Next slide. So certain things we need to know when we initiate an SGLT2 inhibitor. First, we have to ensure the eGFR is above 30 before we start. That is to ensure it will cause glucosuria and have the beneficial effects, and all the studies were based on that. We usually start with lower dosages in order to allow the patients to adapt. We know that it causes some glucosuria and therefore some decrease in volume. So if patients are on many other antihypertensives, the fact of starting with lower dose will minimize the risk of hypotension. Next slide. We have to counsel, therefore, about hydration and SAD/MADs. In other words, if they're sick, it's one of the agents that they should stop. So if they cannot eat or drink normally, if they feel really sick, it's better to stop these drugs until they feel better and can eat and drink normally. Otherwise, they have more chances both of dehydration, because the kidney will have to get rid of the glucose anyway, so it will send volume even if they're dehydrated, and also more risk of ketoacidosis. Next slide. We have to consider prescribing an antifungal agent. As I said, I always prescribe the cream for men, fluconazole for women. I ask them to buy it, to keep it at home in case they have symptoms that start, even if it's the middle of the night, they have something to stop it rapidly. Next slide. We have to consider the risk of hypotension. So if it's above 130 or 80, the blood pressure usually, it gives us enough margin. We don't need to adjust the others. But if it's more normal, then we need to consider reducing them, and particularly the diuretic, we can often stop or decrease in order to allow room for the effect of the SGLT2 inhibitor. Next slide. And finally, the risk of hypoglycemia. So again, by themselves, they never cause hypoglycemia. But if somebody, for example, is on insulin, the fact of improving diabetes, it might allow insulin to become too strong and cause hypoglycemia. So if the A1C is high, if their glucose levels are high, we have enough margin that the improvement will not bring them in hypoglycemia. But if the glucose control is reasonable, if it's under 8 of A1C, close to target or at target, then we might have to reduce some of the agents that might cause hypoglycemia, namely secretagogues that could be reduced by half, or insulin that could be reduced by about 25%, and then, of course, readjusted. And finally, it's important to remind the patient to follow up with the diabetes care team so that we can readjust these therapies to maintain the best glucose control possible. Next slide. So this is the SAD/MAD sheet and the guidelines. So the SGLT2s are the final S in SAD/MADs. The tear-off sheet that we can print from the guidelines also suggests some other agents that should be stopped when patients have a concomitant disease where they can't eat or drink normally. That includes ACE inhibitors, ARBs, and diuretics and direct renin inhibitors. It also includes sulfonylureas to avoid the risk of hypoglycemia. It includes metformin in case there is an acute renal failure, so that metformin doesn't accumulate. It includes non-steroidal anti-inflammatory because of the potential dehydration might induce acute kidney disease with these agents. So the SGLT2 inhibitors are part of that group. On the tear-out, there's a place on the right where there are lines. That's where you can actually write the names as they know it of the patients, whether they have generic or some original medication. So if they know the medication as Jardiance, well, you can write Jardiance, and then if they know another one as Perindopril, you can write it, etc. In the name that they will know on their list. Next slide. When initiating a GLP-1 receptor agonist, a few other tips we usually need to refer to diabetes education or pharmacy because they have to inject. Fortunately, it's very simple, so it's not a long teaching. I often do it myself in the office, but certainly for cardiologists or often family physicians, they'll prefer to send it to other people for the teaching. Next slide. We have to counsel about the GI side effects. So we start again with the lower dose, and we wait till that lower dose has been well tolerated for a week or two. And if yes, we can slowly increase the dose and go towards the maximum dose slowly to ensure it's well tolerated. If they do have symptoms, while we wait till these symptoms go away before increasing, it's no use if they have bad symptoms with a certain dose to push even more the dose. They'll just go to the point of not just nausea, but potentially vomiting. Next slide. So other tricks, if they have bloating or nausea, to eat smaller meals. The dose can be lowered and then re-increased over time. And eventually, as the symptoms decrease over time, we can increase the dose. What do we do with the other anti-hyperglycemic therapies? Same concept as with the SGLT2 inhibitors. We have to take that into account. Now, the DPP4 inhibitors are part of the same class. They're incretin agents. They work through GLP-1. So whatever the A1C, we usually stop the DPP4 inhibitor when we give a GLP-1 receptor agonist. Otherwise, it's not dangerous to leave them, but it would be an unnecessary expense. If the A1C is close to target, then to avoid hypoglycemia, because the diabetes will improve a lot with the GLP-1 receptor agonist, we need to reduce either the sulfonylureas or the insulin dosages to avoid hypoglycemia, and then, of course, readjust based on the glucose levels. And we have to teach them, of course, about the risk of hypoglycemia. And finally, to have a follow-up with their diabetes care team. Next slide.
If we go back to Irene, what will you do about her diabetes? Remember, the A1C is 7.1. She's a secondary prevention patient, already treated, but without a GLT2 inhibitor and without GLP-1 agonist. There are different options. I think A could be good, but not only A, to send Irene to diabetic center to review her diet and activity. I think this is going to be good for the future. This means that we're going to help her to change the way she lives and help the weight management and improve physical activity. I don't think that to give Irene another 3 months to improve her blood glucose is a good option because she's already well treated. She's long-standing diabetes. She's diabetic since 2011. I think she had enough time to improve her glucose control with health modification. I think based on the current guidelines and because she's on secondary prevention and A1C is not our target, SGLT2 inhibitor should be considered. Same thing because the IMC is above 30. She could be a good candidate also for a GLP-1 agonist. If you're not confident to introduce this kind of compound, I think Irene could be a very good candidate to be referred to endocrinologist. And also, as a cardiologist, if I'm not very confident to start SGLT2 inhibitor or GLP-1 agonist, I think, and we know that this patient is nicely followed with general practitioner, and I think I can write a small note to a general practitioner that saying that, do you know this patient could be a good candidate for GLT2 inhibitor or GLP-1 agonist based on the fact that she's on secondary prevention, and we expect a good CV benefit with the introduction of this compound. Next slide.
So Jean, if we think of a cardiologist, probably F would be the easiest, probably a minimum.
Yes. Mm-hmm.
And do you think many will become quite familiar with C and D? Do you think it it will become like statins in the future, or do you think because of glucose levels, F might remain more the general approach with your colleagues?
But I think this is a very good question, and based on the fact that this kind of compound improves cardiovascular outcomes, we're more talking about vascular protective effect of SGLT2 and SGLT1 agonists. And based on this, I think more and more cardiologists will have to be, proactive to introduce the drug. And in the future, I think based on the fact that this, at least the SGLT2 inhibitor, improve outcomes, reduce heart failure hospitalization, this will become, I think, a medication that cardiologists should be able to prescribe and should be more and more confident and feel more secure to prescribe over time. We'll see. Yep.
All right. Thanks so much, Dr. Yale and Dr. Gregoire. That was a really interesting talk. Really great data. So there's a few people on the line. Maybe right now we can just open it up, and if you have questions you would like to ask, feel free to speak up and ask your questions.
I have a question for Jean-François. When you're talking about diuretic treatment, and you describe maybe because the SGLT2 inhibitor reduce the volume, do you make a difference between the thiazidic diuretic versus the furosemide diuretic? Is there a different option when you introduce the SGLT2 inhibitor in patient already on thiazidic versus Lasix?
Well, certainly, if it depends a little bit on the general condition of the patient. So, if the diuretic was used mostly for hypertension, which is more the case when it's hydrochlorothiazide or a thiazide-like agent, then usually you can just stop it if the blood pressure is pretty much in the normal range. If, however, the diuretic is given in part for symptoms of heart failure or related, such as edema or shortness of breath, and there might be a component of heart failure, and that is often the case when furosemide is used, for example, then I tend to be a bit more careful to not induce any worsening. So the way I do it is depends a little bit on the dose. If they're on a high dose of furosemide, I might reduce it by half, but I usually give them the same if they understand well, depending on their cognitive abilities. I usually leave them the same prescription, but I'll tell them take half of what you were taking. And if you see that your swelling increases or you become more out of breath, you have the ability to go back up because the prescription has not been changed. So, if they take 80 milligrams of furosemide, 40-40, I might say, well, decrease to only 1 of 40, but if you need, you can re-increase if you see that you have too many symptoms. So that way, it prevents negative effects to happen, but it's safer in the short term.
Hi, Dr. Tarakchari speaking. I'd like to know, the patient who is on spironolactone, is it the same as furosemide?
I would say yes. I don't know what Jean thinks, but in my view, there is a potential. Again, we're only talking if the blood pressure is in the normal to lower range. What we want to avoid is hypotension. In other words, if we're going to have an impact in the next few days, we want to avoid symptomatic hypotension. We prefer to have the blood pressure go up just a little bit. But again, if it's given with the concept of heart failure, I would, as a safeguard, make sure that they can reintroduce the therapy if they worsen when that therapy is decreased or stopped. And just to be sort of on the safe side. That being said, the SGLT2 effect is usually extremely fast. We see it by the mortality results and the heart failure results that usually seem to happen within hours. You can see the graphs separate. So it's a very fast effect, so that usually it will be as potent as many of the diuretics, including aldactone. So usually there won't be this worsening. If anything, they'll often improve.
Yes, and I will add, Jean-François, for aldactone, probably depend on the dose. If the patient is taking a very small dose, 12.5 milligrams of aldactone, I won't be too much worried about the impact on volume. But if the dosage is higher, probably the best is going to be to cut the dose by half. For example, aldactone 25 reduced to 12.5 and see what's happened. But the diuretic effect of MRA is less important than the hydrochloride, for example, and certainly less potent than Lasix or furosemide.
Thank you.
There's a couple questions that came in when participants were registering for the program. And, if we just have a couple of minutes, perhaps the two of you would like to touch on a few of these if you can.
Well, I can start maybe with number one and we can alternate. So is cardioprotection with SGLT2 inhibitor dose dependent? Well, certainly in EMPA-REG, they were clearly identified and the data were presented separately for the low dose, the 10 milligrams, and the high dose, the 25. And the results were in every aspect absolutely superimposable. So there doesn't seem to be a dose dependent. Even for glucose and for weight, the majority of the effect occurs with the small dose, like 75%, 80% of the effect. You only get a little bit more effect on A1C and weight when you push the dose. But in terms of cardioprotection and renal, there's no dose dependence. The low dose will do the job.
For the second question, what are some of the latest study data in type 2 diabetes and the cardiovascular disease? As you know, there have been the last study with the SGLT2 inhibitor was DECLARE, and DECLARE randomized patients mostly in primary prevention, 60%, 40% in secondary prevention. We already showed that the patient in secondary prevention has some benefit regarding cardiovascular event reduction. This one seems to have a strong effect with the SGLT2 inhibitor in patients with primary prevention, but you have to remember in the DECLARE, patients were randomized with eGFR above 60, and the kidney function is probably a very strong risk factor for cardiovascular event and cardiovascular manifestation. This means that when you identify diabetic patient with normal eGFR, the risk to develop cardiovascular event is probably less important compared to a diabetic population with lower eGFR. And I will let Jean-François to describe probably credence some interesting data regarding the kidney function in the diabetic population with the SGLT2 inhibitor. I think this is very important data and very new data also. If you want to describe
credence specifically in a population that had renal disease. It's again a long-term large trial with only 100 milligrams of canagliflozin. There was only one dose, and there was a very spectacular impact on renal outcomes, which was the primary outcome. Interestingly, in that study, there was also some cardiovascular benefits that were quite strong, and there was no risk of amputation. So that study was quite impressive in that population, that there seems to be a very clear benefit in people with either proteinuria or with a lower eGFR. Other latest study data to come at the ADA, so in a few weeks, will be the data with the GLP-1 receptor agonist dulaglutide, so the REWIND trial. They always have to make an early announcement for the investors, and it's been announced that the results will be favorable, beneficial. We have no details yet. So to follow, it's in the second week of June that we will have those data coming out, and many other studies are going to come a little bit later. what is the real world data looking like? There was CVD Real, which was sort of done in response to when empagliflozin came out, Empareg, and empagliflozin was the only data available. So CVD Real was a little bit of a response to try to see what happened with the other agents, and they showed, in general, sort of class effects. If anything, I would say probably the results were even better in the real-world data, sometimes in a spectacular way. Of course, when reproducing what has been done in clinical trials, I think we can believe it, and it's reassuring to see that they see it. When there's more to be seen, results even more spectacular, like reduction in mortality, things like that, across many populations, we always have to wonder, when it was not present to that extent in some of the trials, whether there's biases, like in any real-world data, that might interfere to make it look even better. But certainly, if anything, it was as good, if not better, on real-world data. I don't know if you have some comments, Jean, on that one. So if not, the next question is, can we combine Jardiance with Victoza? The answer is yes. That has been shown, not in cardiovascular trials, but in other trials. And the effects are additive in terms of glucose control and weight. And finally, what are the best options?
We can expect some synergistic effect regarding cardiovascular event reduction? Because we know that the SGLT2 agonist and the SGLT2 inhibitor improve cardiovascular event in the high-risk population. Is
Certainly
there any
to be hoped
trial
for.
currently? Yeah.
So I don't think there's any trial with both in terms of cardiovascular impact.
Okay.
Theoretically, there might be reasons to think maybe it would not be necessarily synergistic or additive. I think we hope it is, and certainly for now, most of our clinical decisions are based on the fact they might be, that the effects might be independent. But certainly, if the beneficial effects of Jardiance are related to an increase in ketone bodies, there's the opposite effect seen when we give a GLP-1 receptor agonist. So if the beneficial effect of Jardiance are related to volume, they should be totally independent from GLP-1 receptor agonists. If the effects are related to the metabolic pathway, so more ketones available as fuel for the heart, this might be reduced by giving a GLP-1 receptor agonist. So in theory, it could go both ways. But in general, for now, most people seem to take the option that probably giving both is better than giving either one alone. I don't know what's your opinion on that one, but
we might be interesting to see the data in the future, and mostly with the SGLT2 inhibitor and GLP-1 agonist, with the potential mechanism to improve cardiovascular outcome. And then if we identify what the principal mechanism would be, the combination could be helpful in patients. But sure, this is going to help to reduce the A1C and improve glucose control, at least.
And the final question, what are the best options for patients with decreased renal function? I think we can say that if it's between 30 and 60, we must give an SGLT2 inhibitor. It really has renal protective actions, as shown, for example, in Credence, but also in all the other trials. If they're under 30, then we can't give an SGLT2 inhibitor. A GLP-1 receptor agonist, however, can be used at very low eGFRs, and then it becomes probably the best option in those patients.
All right. So the next steps for the participants of the program, it's likely that the physician profile has already been done. The patient assessment step is live. You'll get another email about it. And then the consultancy meetings, the English one is on Wednesday, May 29th from 6:30 to 9:30 p.m. And yeah, there'll be a follow-up email from this webinar looking to gather your travel, accommodation needs, etc. And so with that, we'll close it out. Thank you so much, Dr. Yale. Thank you, Dr. Gregoire, for taking the time tonight. It was a great webinar. And everyone, hope you have a really nice evening. Take care.
Good night, everyone.
Have a great evening. Bye-bye.
Bye.